Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Nicholas Strasser from Nashville, Tennessee, United States. Dr. Strasser is a board-certified orthopedic surgeon specializing in foot and ankle surgery with a focus on sports injuries, minimally invasive techniques, and return to sport strategies. He completed his orthopedic surgeon residency at the Mayo Clinic, followed by a fellowship in foot and ankle reconstruction at North Carolina. Dr. Strasser practices in Nashville, Tennessee, and is the founder of Orthopedic Indications, a rapidly growing educational platform for orthopedic surgeons, trainees, and medical professionals. He's an invited lecturer, surgical innovator, and advocate for advancing evidence-based foot and ankle care through education and digital platform. If you've noticed, Dr. Strasser has delivered a lecture on a channel and it's already reached a huge audience. And today is my great honor to bring back Dr. Nicholas Strasser for this wonderful live program. Over to you, Nick.
Thank you very much. Super excited to be back here. Always love catching up and across the world. And as you said, from Nashville, Tennessee. So thanks again for the opportunity. Today we were talking about different things to talk about. So I thought what I would hit on is talking about Lisfranc injuries in the athlete. And I think it's very different than, say, some of the other injuries that occur. Like if you talk about Lisfranc injuries, there's two basic types. There's the one that occurs in the athlete, and then there's a type that occurs in kind of the high energy. And so the point of this is to kind of focus on how do we manage this in the athlete. These are my disclosures as they pertain to the talk today. I think everyone is familiar with Lisfranc injuries or midfoot injuries, and especially if you think about the eponym associated with this. One of the field surgeons in Napoleon's campaigns was Jacques Lisfranc de Saint-Martin, and he published in 1815 on partial foot amputations, and this was more in relationship to some of the gangrenous battlefield injuries that occurred in some of the cavalry soldiers, and was a disarticulation to the tarsometatarsal joint. Now, in today's world, we think of this when it gets mentioned, it's more of a spectrum of injury to the midfoot, and we still reference it when it comes to amputations, although that's much less common, at least in the United States. But we think about this in terms of sprains, dislocations, and fracture dislocations, and it's important because sometimes these can be missed, and especially in the more subtle injuries, the lower energy injuries, and oftentimes they do need surgical treatment, and if we miss them, they can lead to chronic pain and disability, arthritic changes. One of the athletes I think is kind of interesting to look at when you talk about athletes and injuries, and particularly in the United States, it's football that can be such a high incidence of these, or relatively high incidence. And one is Jordan Lewis, who played for the Cowboys about 2022, so a few years ago. And basically had intercepted a pass, and as he was getting tackled, sustained this pretty horrific injury. And this was from an article out of the Dallas News, kind of showed the different x-rays before and after, and you can see a pretty catastrophic injury. And it was amazing that he was able to return to play in several games the following year, which is pretty incredible when you think about the severity of the injury. So these definitely can occur, and most of the time we think about these as being relatively low energy, but something like this almost looks more like a motor vehicle accident. So we have to be able to manage the spectrum of the injury. So maybe one case to kind of start with, this is an 18-year-old healthy male who sustained a basketball injury when he landed on someone's foot after he came down on for a rebound, and felt a pop, couldn't walk on it, kind of limped off, and eventually showed up in my clinic when he was referred by one of my colleagues. And if you look at the x-rays initially, relatively unremarkable, meaning that there's maybe a little bit of widening in the Lisfranc complex between the base of the second and the intercuneiform space. But if you get weight-bearing X-ray, it gets a lot more helpful. You can start to see the gapping on the left foot there in the intercuneiform space. Lateral view looks pretty unremarkable on these weight-bearing X-rays, as they oftentimes do. And if you look at the MRI, which can be a little bit tricky, you see some bruising in the web space, or in the second tarsometatarsal articulation. And if you go back and look at the tarsal metatarsal joint of the first ray, you actually see some capsular injury. There's the bone bruising there on the axial images, and then here we come through, we can see the disruption of the Lisfranc complex. Now, it's a little bit tricky because you have to be able to think about this in the plane in which the ligament runs, and we'll talk more about the anatomy here in a second, but here's kind of a representative view of what we can oftentimes see. It's a relatively rare injury when it comes to athletics, but it definitely can occur. And I think of these in thirds. So about a third of these are going to be low energy injuries, and other 2/3 are going to be high energy, oftentimes like motor vehicle, falls, kind of things like that. One thing that I think about a lot of times is in these lower energy can oftentimes be coming down and not sport related, but coming down stairs. Oftentimes I hear that for kind of the general population. So something to kind of be thinking about as you see these patients in your clinic. These can be career altering, and they're oftentimes underdiagnosed. They get missed. And so we want to identify them early, because as you look across some of the different professional leagues in the United States, we see a relatively high 80 to 90% return to play, 73% in the NBA. But it takes a long time, miss about a full season. And it has significant economic costs, and there is some evidence that there's some performance decline, particularly during that first season as they return. If you look at the incidence across the NFL, it's about 2.5 to 3 average that occur per year. That's from 2009 to 2020. Usually the mechanism is going to be kind of the foot's going to get loaded on, axially loaded from while the foot's plantar flexed. Here's an example that you can see. He's landing on the foot there as it's kind of on the outside part. So sometimes it can have more of an abduction type force. And especially in the cleated athlete, the foot gets planted, the heel's lifted. There can be some axial load or even rotation, as you can see here. Gymnasts and dancers, sometimes they fall, sometimes they're barefoot, and then they land awkwardly on the foot and can create that axial load in that particular situation. I think probably everybody's familiar with the anatomy, but you have to be able to understand this because if you don't know, you're going to miss some of these injuries. And it's really important as we look at the base of the second metatarsal, and it sits in a recessed area, kind of like a keystone we talk about in the Roman arch. There was really no intermetatarsal ligament between the first and second. Instead, the stability is from the Lisfranc complex, which runs from the base of the second to the medial cuneiform. And we need to have the rigid structure because as we go into generate power, as in push-off phase of gaits, we need a stiff lever to be able to push off against. And so that's some of the reason we need to make sure that we maintain that integrity. If you look at the transverse arch, the second metatarsal sits in a recessed position relative to the medial cuneiform. And then the ligamentous stability comes from 3 bands across that make up the Lisfranc complex. You have the dorsal band, which is obviously on the more dorsal surface. You have the interosseous, which is a little bit more difficult to fully define. And then the plantar band, which seems to be the primary stabilizer, the strongest portion of the band, strongest portion of the ligament in this particular case. Why does it matter? Well, we need that stability. Like I said before, we don't have an intermetatarsal ligament between the first and second. So if we disrupt the Lisfranc complex, now we lose the stability. We need that stabilizer to help give us that rigid ability to push off. And even a couple of millimeters of diastasis can cause significant instability, difficulty with push off, arthritic changes. So restoring that alignment is especially important in the sagittal and coronal planes. Plantar bruising is one of the things that you need to be thinking about. And if you see this come into your clinic, if you're seeing patients in the emergency room, you need to be thinking about this as the injury. If they show up and they have plantar bruising, you don't want to miss it. So that's one of the things that you really need to be kind of keep in the back of your mind, because these can get missed. They can get chalked up as just an ankle sprain. So always look at the bottom of the foot for any sort of plantar bruising. If you have a really substantial injury, you can get tenting of the skin, so you want to be aware of that as well. You need to be able to look at radiographs and to assess these and be able to, because the findings can be relatively subtle. So you have to be able to take 3-view foot x-rays. I like to get weight-bearing x-rays. I think that really helps me understand the anatomy and the injury pattern. So if you, and I'll oftentimes get a bilateral AP x-rays so that I can compare to the contralateral side. Here's a case where you can, where I'll look at the base of the second metatarsal relative to the middle cuneiform, looking for any sort of step off. You can see on the image on the right that there is diastasis, there's subluxation at the second relative to the middle cuneiform or the intermediate cuneiform, which is not present on the left side. The other thing on the AP view is you need to look at the first TMT joint. I think that gets under-recognized sometimes, that sometimes there's some subluxation at the first TMT joint, and you will see that in a case a little bit later where that actually, I think, was the primary cause of the instability in these particular cases. And then an oblique view, you want to look at the base of the third metatarsal relative to the lateral cuneiform, looking for any sort of step off. So you can see the example here on the right that there's some subluxation of the third relative to that lateral cuneiform. You can actually see sometimes a little bit of subluxation of the second. If you look at the lateral border of the second and the lateral border of the intermediate cuneiform, you can see some subluxation as well. So keeping those things in mind as you assess these x-rays, again, sometimes getting a comparison view is extremely helpful from the other side. And then on the lateral view, and I see this less often, but I start to see it more in the kind of chronic situations. And this is a case where you can actually see a little dorsal subluxation of the base of the first relative to the cuneiforms in this case, and the normal on the right side, on the other side. Obviously different patient, but you can see the subluxation in that case. So in addition to the widening or malalignment at the tarsometatarsal joints, the other things we can sometimes see are flex signs. Flex sign is just a small avulsion on the base of the second metatarsal. Usually it's where we'll see it. Sometimes I can actually see that a little bit better on a CT scan. Sometimes you're going to see things like cuboid compression or edema on something like the MRI or the or CT scan. You see a little bit of compression as you get that subluxation and abduction force. But again, as I said, weight-bearing x-rays, I think, are critical. Even if they're really painful, I think repeating them in a couple days, a week, I'll bring them back. And you could consider even just doing, if they can do it, standing on one leg and compare to the contralateral foot for anatomic variation. MRI can be really helpful as well. You have to study a lot of these. I think you got to study normals in order to pick up some of the subtle findings. That the angle of that Lisfranc is a little bit off axis to where some of these axial views are going to be. So you have to look at multiple views in this case. It's been studied in the literature. You know, how accurate is this? The downside of the MRI is it's not dynamic, meaning it's not, can't stress it as well, at least not yet. And so being able to study it, I think, takes a little bit of work. If you look at this particular study, what they looked at was 27 patients with an acute Lisfranc injury that had MRI and surgical interventions. And what they looked at is the integrity of the Lisfranc. And basically what they found is if you could, that the Lisfranc complex was really the key to being able to assess these injuries. The dorsal and interosseous are a little bit less reliable when it comes to assessing it. So I'm really looking for that Lisfranc ligament. That's really helpful. And I will also look at, especially the ones that I already know are unstable, I'll look at that first TMT joint, because sometimes you start to see that sublux a little bit as well on the MRI, or you see disruption of the fibers on the medial side. And that can help just key me in as to, do I need to fix that part, or is that relatively stable? So for the takeaway from my perspective is it's reliable for confirming Lisfranc disruption. Remember, it's not dynamic. And if you do start to see widening on the MRI on a static exam, I think that's injury. That's indicating that the injury is probably pretty unstable in that case. And sometimes we'll see those subtle findings on the MRI. CT scan can be helpful. I do not have access to a weight-bearing CT scan, but this is one injury which I think would be incredibly valuable. This is a case of a younger kid. You can see open physes, but if you flip it around, and oftentimes we'll use three-dimensional imaging to kind of really study it, you can actually see the flex sign on the base of the second metatarsal here. And sometimes when I convert it to a 3D recon, now I start to see more subtle dorsal subluxation of some of these metatarsals. So I think a CT scan, even if it's a static exam, can actually be quite valuable. My general algorithm, and again, this is not hard fact, but if I get x-rays and I do not see, and I suspect widening on weight-bearing x-rays without fracture, I'll oftentimes get an MRI, especially in the athlete. Very reasonable to also get a CT scan in those cases as well. If I see fractures, then I will usually get a CT scan to further assess that. But that's generally my approach. But you could certainly talk me into doing it differently. Classification. So Meyerson described this great classification. This is pretty classic. I think everybody is relatively familiar with this. This is going back to the mid 80s. But this I think about more in high energy motor vehicle falls, like that kind of stuff, that instead of thinking of this or applying this in the athlete. Now, certainly you can see some of these in the athletic situation. We looked at that injury earlier on that looked more of this kind of divergent injury that occurred. But generally speaking, I reserve this for the higher energy kind of situation. Nunley described stage 1, 2, and 3, where stage 1 was basically a sprain without diastasis. Stage 2 had 2 to 5 millimeters of diastasis. Stage 3 had diastasis with dorsal subluxation on the lateral view. I actually really like Porter's article from a few years back out of FAI, and he did a great job of basically expanding on the stage 2 injuries that Dr. Nunley talked about. So this helps me because I can actually think about how I want to fix them based off of the patterns that are involved in this particular case. So you have 3 different types. You have traditional, you have medial column, you have a proximal extension. So what do those look like? The medial, the traditional tear affects the ligaments attaching the medial cuneiform and the first metatarsal, so the first TMT, the medial cuneiform to the second, that's the Lisfranc complex, and then the middle cuneiform and the second metatarsal. So you can kind of see this is kind of the traditional thing that you can see on the weight-bearing X-ray there. You can actually see a little bit of subluxation at the first TMT joint with widening of the Lisfranc complex. The medial column dislocation injury affects medial cuneiform to the second metatarsal, and it's almost like that medial side kind of splits off. And I've seen this more and more in football now. I just had one this last week where it's almost like this medial column, energy comes out through the Lisfranc complex and then out through the navicular cuneiform joint. And then you have this proximal extension variant, which has the first TMT joint, the Lisfranc complex, the second TMT, and then injury into the intercuneiform space as well. So trying to identify these, I think, can be actually helpful in thinking about how we fix these. And I'll get back to more of those here in a second. What about surgical treatment? You know, we talk about primary ligamentous injuries, and there's been this thought of using primary fusion for managing these. So the question is always raises, like, do we need to be thinking about a primary fusion for some of these injuries? And so it's something to consider. I'll talk about that a little more in a second. Generally speaking, when I approach these, I think about approaching these proximal to distal, medial to lateral. Incisions are going to be largely dictated by the injury, and I'll expand on that in a second. Why did I mention primary fusion? Well, if we go back a few years ago, Kutsia talked about using primary fusion for treatment of these high energy primary ligamentous injuries because the incidence or risk of developing arthritic changes after ORIF was incredibly high. And if you looked across the scores, they had better AOFAS scores with the fusion and a better return to activity when compared to an ORIF with lesser reoperation rate, as you might expect, because a lot of the times in these ORIF, we're going to go ahead and remove the hardware down the road. Now, that admittedly is a little bit debatable, but it's certainly something you have to be considering. So, you know, it's something to consider, and it raises the question oftentimes, do we need to be thinking about the primary fusion? Well, if you look at further meta-analysis that have come out, you know, there's been additional studies that have been done beyond that. And, you know, generally speaking, I have no problem thinking about doing a primary fusion for a primary ligamentous injury in a relatively young patient. That being said, in my athletes, I'm primarily thinking about doing an ORIF because I really want to try to preserve the anatomy as much as possible. And if you look across now some of these other studies that have come out, focusing on these ligamentous injuries, AOFAS scores, fusion might be slightly better. It's a little bit closer together than it was shown before. No significant difference in VAS pain scores. Return to activity scores have been relatively similar. And obviously, reoperation rate is going to be higher in the ORIF group because I think more people are going to be thinking about taking out hardware. Again, debatable. Maybe you don't necessarily need to be that aggressive taking out hardware, but that's going to be the case. If you take the ORIF group, there's just going to be higher, even if you don't plan to return to the OR. So how do we treat the athlete? You know, a fusion may reduce reoperations. It may improve functional outcome, but in my hands, ORIF is still my preferred treatment in the athlete because I want to try to preserve the motion as much as possible. And you have to have kind of a shared decision-making and tailor this by activity, the injury, and what they're trying to get back to. So again, coming back to Dr. Porter's article out of FAI, which probably has the largest number of athletes that were kind of followed over time, it had 82 patients, competitive athletes, pure ligamentous Lisfranc injuries. Now, admittedly, master surgeon, extremely talented, follows things closely, very well thought out treatment algorithm in the way that these get managed. So you want to take that kind of with a little bit of a grain of salt, but I think what you find here is that they had an extreme high rate of return to sport. 92% of athletes could return to their pre-injury level of competition at an average of 7.5 to months. So I tell patients, what I'll tell my athletes is there's a very good chance we can get you back to sport. And it's probably, I tell them 9 to 12 months. I figure that gives a little leeway. If it's faster than that, great. But it admittedly takes a little bit longer than you would like to think. And hedging on closer to 9 to 12 months seems to be a pretty safe window. And there's some debate on whether you take out hardware or not, but I'll talk a little bit more about that in a second. In the United States, the NFL return to play in performance has been looked at. It's always a little bit tricky interpreting this data because this is a publicly available data injury report. So you have to take that with, we don't necessarily know what's going on, but to the best of our knowledge, this is what they tried to do. And they looked at what their return to rate play was, and they showed it being at 81%, 82%, about 11 months to return to sports. So not quite as high as Dr. Porter's article. The performance decreased that first year post-injury, so that really went down. Their value, I guess, went down. Snap count and games played, there was really no significant change. Older patients are less likely to return to play. That makes some sense. Positional trends, defensive linemen improved quite a bit. Quarterbacks had the largest drop. So I thought that was kind of interesting. Quarterbacks had the biggest costs, $32.6 million, compared to other positions, and offensive or in running backs had the least salary effect. So high cost burden, especially for quarterback, that can be a big deal, and you need to make sure that you kind of understand this to understand what the expectations are after returning to sport. What about fusion if you had to do it? So coming back to this question again, this is out of HSS. This is a retrospective review of 38 patients who underwent what they called a primary partial arthrodesis in relatively young patients and followed their functional outcome. And what I thought was really interesting is they called this a primary partial fusion. It could be the first 1 or 2 TMT joints, but there's quite a high number of these as being all 3, first through third TMT joints, which I kind of consider a complete fusion because very rarely am I ever fusing the 4th and 5th. But they included that as a primary partial fusion, standardized kind of techniques, post-op rehabs followed, the usual things. And what they found is that 97% returned to some activity. So that part I think is pretty safe. About 2/3 returned to their pre-injury activity level. High impact sports were still possible, and overall pretty good satisfaction rate. But there's 34% report increasing difficulty. 1 out of 4 had decreased participations, and the patients who were lower had lower FAOS scores. So it's an option. I think it's something that if you felt like you needed to use it for a particular case where there's a significant amount of comminution, articular delamination that's just too much to overcome by fixing it, or in like they come in chronic, now they got degenerative changes and they're asking, what if you do a fusion, can I get back to activities? I generally think that they can. It's just my preference coming out the gate for kind of a straightforward ligamentous injury is going to be to fix it initially. One other study, this out of the military, my friend Joe Bellamy and crew looked at these low energy Lisfranc injuries, and 72% had primarily ligamentous injuries, isolated instability of the first and second rays. They did ORIF with screws, but they did compare it to a primary fusion group. And what I thought was so interesting here is they had actually slower post-injury run times in the ORIF group compared to with the fusion group. So The outcome scores were relatively similar at about 35 months. There was some, anticipated minor and major complications, and ORIF is felt to be safe. A little slower return to full recovery compared to fusion, but similar long-term outcomes. So I think that part's pretty safe. And implant removal was pretty common in the ORIF group, but lower risk, but generally low risk. So something reasonable to consider. Again, where do I use fusion? And in the athlete in particular is going to be the arthritic situation. So they come in, they've had surgery, they are now having problems because they have arthritic changes. The revision situation, perhaps, depending on the status of the cartilage, or maybe the neglected or missed Lisfranc. Severe intra-articular comminution, or if there's substantial articular delamination. Those are the cases in which I would consider, or at least counsel them, that it would probably be okay to do, and you could still get them back to a high level of activity. How do you approach these? So that's one of the big questions, and it really depends on the nature of the injury. I would say this is a fairly typical representative image of how I would approach this. And what I like about this approach, kind of going right over the Lisfranc complex, is I can kind of use windows, kind of create different windows, almost like, your pelvis approaches. You have different windows, you work around the neurovascular bundle. And so if I have to get to the first, to plate the first, if the first is unstable, I can do that. If I have to get over then to the second, I can do that. Sometimes I will use some accessory incisions for clamps or perk screws as well. If I do have to get to the first or third, then I'm good. And it depends a little bit on the nature of the injury, but let's just say it's primarily ligamentous injury. Then I'm going to do 2 incisions. I keep my incision a little bit, maybe a little bit more dorsal medial than this picture shows. So I get a little bigger skin bridge. And then my other incision's a little bit more lateral to help kind of keep that skin bridge as much as wide as possible. But it allows me then access to kind of the dorsal medial surface of the first TMT joint, and then I can get to the second and third TMT joint. Now, if there's fracture, and that's a little bit different situation, I might adjust accordingly depending on where I want to put plates and screws, and et cetera. Again, I mentioned this earlier, but I'm working proximal to distal, working medial to lateral. So typically try to start across that whole thing, and then work your way from one side to the next. And doesn't necessarily mean I put all the fixation in that way. I'm just talking about like getting the reduction sequences where I put my K wires, and then sometimes I'll put the screws in accordingly. So coming back to the case, like how are we approaching this? I use this incision because I felt like I needed to, I didn't need to get, to the third, basically. So I stress all of these initially. So I put a hand, you can kind of see my hand on that image on the left, and then my hand over the toes, and I bring it into abduction to really stress. I want to see what the first TMT joints, what that's doing. And you can see, if you look, let's see here if I can get the laser pointer right here at the first TMT joint, you can see subluxation at that level. So what I'll do right out the gate is I'll go ahead and pin it, and I'll make sure that's reduced here. Sometimes I'll open that capsule and look at it as I did in this case. And that's where having the 2 windows is nice. I probably keep this incision just a little bit more medial than what they're showing here on the diagram. But so I'm right, my incision's right here, and then I can get 1 window into the first, and then I can get 1 right into the Lisfranc complex. I can look right in there and clean all that garbage out of there. And that's what I'm doing here. Here's the approach. You got the neurovascular bundle. I'm retracting this medially so I can look right in the Lisfranc complex. I got my freer in there. I'm kind of lifting up the torn dorsal fibers in this case. And then I'll use a little lamina spreader to open that up, get in there. You can see that's the base of the second. That's the base of the medial cuneiform. And then you see the inner cuneiform space kind of gapping open a little bit there as well. So then I go in and I use a little pituitary rongeur. I get all of that clot and stuff cleaned out of there, make sure I get it all cleaned up. Now, there are some that say it's okay to do this completely percutaneously. I wouldn't necessarily disagree with that. I personally feel that I would rather open it, look at it, and see it, because I've seen enough cases where I go to put the clamp on and it subluxes just a little bit and I can't tell, or there's stuff that's like stuck in, the capsule or the ligaments are stuck into that Lisfranc complex. So my personal preference is to open it, clean it out really well. Now, and it's a little bit of dogma. It's a little bit of the way I was trained. So you have to keep that in mind. But I find that's been a very safe thing to do. Pull the Lisfranc, pull make sure you retract the neurovascular bundle, clean it out really well, and then go ahead and put your fixation in. So then you can see I've got the first tarsometatarsal joint pinned. Then I go ahead and put a clamp onto the base of the second, and then I make a separate incision on the medial side of the foot, clamp that looking right at it, make sure it doesn't sublux on me at all. And then I'll go ahead and put my wire, and I'll put my wire from lateral to medial. I find that's easier. Some people will put fixation from medial to lateral, totally fine, whatever your preference is. For me, it's easier the placing those are easier to do from the angle of where I'm standing, and it makes it a lot easier. So here we go. Here's our fixation that's in. So I went ahead and bridge plated. My preference is if I'm doing an ORIF, I'm going to bridge plate because I'm trying to preserve cartilage as much as possible. I realized for a long time we put transarticular screws, but in the athlete, in this situation, I'm going to go ahead and bridge plate it, and I'll use a couple of locking screws in the cuneiform and non-locking screws in the first to make sure that's restored. And then in this case, I use cannulated screws. You can use solid screws. I'll show cases where I use solid screws as well, with intercuneiform fixation as well in this case. So then this is his follow-up x-ray at 3 months or 4 months, fully weight-bearing on it. He elected to get his hardware out. I think it was closer to 6 months post-operatively, which was very reasonable from my perspective. And I've maybe softened on things a little bit when it comes to removing hardware, but I'll still take it out most of the time, particularly in the athlete. So 17-year-old male, this is a senior in high school, non-contact football injury. And I show this case for a couple of reasons. One is, he felt a pop. He had difficulty weight bearing. He had a lot of swelling and bruising in the forefoot and in the plantar aspect of the foot. Here's his AP X-ray. You can see widening between in the space between the intercuneiforms here and between the base of the second and the first. Pretty subtle. Here's his his other 3-view foot x-rays, maybe a little bit of dorsal subluxation here, or plantar subluxation in this case, although usually you see it more dorsal, so I'm not sure that's actually real. And then if you look here really carefully, and it's maybe overblown up, but there is actually a fracture line right through here through the medial cuneiform. So here's injury pattern. If we go back, in this situation, is that proximal variant. Essentially injury came through here through in the cuneiform space, and then essentially exits through the fracture pattern here on the medial side of the foot. And it was interesting because he was like, I felt a pop, or I felt pain, and if I have pain in my arch. Not so much in the forefoot, in the midfoot, it was pain in the arch. And I've heard that a couple times. The other thing was it was non-contact. He just stepped back and felt a pop. And I've seen this a couple times as well. Sometimes it happens without the injury that you would expect it to be. So here's the fracture. Here's his MRI. You can actually see the fracture here on the axial images. And as you kind of scroll through it, and you can see the widening right here between the base of the first and second. You can see a little subluxation in the intercuneiform space, and disruption there on the MRI as well, on the axial imaging. There's a fracture right there. And then another view using the T1 images, seeing the widening, the gap between in this space here, just indicating the instability. So here's our X-ray. I stressed it right out the gate. His first didn't look quite as bad. He had a little bit of subluxation, but you can definitely see the widening here. So I went ahead and opened it. Same approach that I just showed. Went ahead and opened it, and I put my fixation in. So the proximal to distal, so intercuneiform space wire, and then the home run or Lisfranc wire. And then in this case, I went ahead, I checked all my views, and then I went ahead and I used solid screws in this particular case. I think it's a little bit of dealer's choice. I've heard dogma on using solid, cannulated. This one I ended up using solid screws just because I knew he was going to be trying to push it and get back, and I wanted as strong a fixation as possible. So solid screws using a cannulated technique for placing them. Another one that's kind of interesting here, 17-year-old male. So this was a rugby injury, and I get a call from one of my peds colleagues saying like, hey, I got this kid in the ER, And you can see this is a pretty high energy injury. This is a full-on homolateral dislocation. You have concerns for the skin. This is what the skin looked like. You know, and that's something that you don't necessarily want to sit on, because that skin is tinted. It's a little bit, it's white. It's definitely threatened in this case. So you can see the CT scan that he got. You can see there's really no big fractures. It was all ligamentous in this case. And this is one of those cases where you're like, okay, he's, you know, late teens. It's a bad injury. Do you consider fusion in this particular case? It's a little bit of the question that you kind of go into it, looking at that as a possibility. And so that's this is a bad injury. This is one in which I used a dual incision. I kept my incision a little bit more medial on this particular case, and then the other one is going to be a little bit more lateral, so I can get to the second and third. And then I went ahead, you know, proximal to distal and medial to lateral. And so in this case here, I started with the first TMT and opened that up through a dorsal medial incision, looked right at it, pulled it over, K-wire in to hold that initially. And then I used bridge plating in this particular case. The cartilage looked fine. When I exposed it all, it looked completely fine. Did not see anything that looked like a delamination or significant articular injury. You know, it's not fine, but nothing that made me think I needed to be considering a primary fusion. The other thing is, he's in on a travel team from a city about 6 hours away. So, you know, that's the other thing in the back of your mind. You're thinking, gosh, I think I'm going to try to fix this, do as good of a job as I can do to fix it, get it right, give him a chance. And then if something happened down the road where he needs a fusion, at least we've set him up with getting his foot back in good alignment. So here's his follow-up x-rays. I use screws across that plate in this situation, all the way across the intercuneiform joint, just to maximize my fixation and make sure I have stability there. And I do that through the plate, and then a couple of non-locking screws down the first, and then bridge plate the third. On the second, I was actually able to get pretty good fixation there with just the Lisfranc screw. So I did not feel like I needed to put a bridge plate on the second. I definitely have done that before, but certainly here is at 2 weeks. I had to go hunt these X-rays down from his dad and a colleague in a neighboring community. But here's at six months. So he's, you know, admittedly, he's got some arthritic changes to the joint of his first TMT and probably his second, but he's back to playing sport, and he elected to leave the hardware in, which I think is completely reasonable, because, you know, as soon as you take the hardware out, you're starting to get some subluxation and more motion. So in this case, I think leaving it in is completely reasonable. A couple more cases. Hopefully, got a little bit extra time here. 17-year-old female basketball player. She had an injury about 9 months before. And so here's her x-rays, and fairly unremarkable. Injured side's the left side. But what you start to see is, if you look at the base of the medial cuneiform and the base of the first metatarsal, you see a step off that you just do not see here on the other side. And then here on the left, you see some dorsal subluxation. If you draw a line kind of through that area, you see that first sits up a little bit. And then if you look at the base of that, you can see a little bit of subluxation as well. So definitely something going on. Here's her MRI 9 months after the injury. They said that on the report, they said the plantar Lisfranc ligament was okay, but there was tearing of the interosseous and dorsal. Again, we don't know if we can necessarily trust that. And there's probably some healing that occurred, because this was fine kind of down the road. And I saw her towards the end of her senior or junior season. She was able to play and participate, but then as soon as the season came to a conclusion, she's like, I can't, it's just killing me and I can't do anything more. And so here's her axial imaging. You can see, I think this was torn here. They said it wasn't, but I think there was a tear of the Lisfranc complex right there. So we took her to the OR, and in this case, we stressed it, and you can see the widening of the first TMT joint. And I was pretty, you know, dialed into that just based off of the studying her MRI. Not as much between the Lisfranc complex. So we went ahead, like we talked about, medial to lateral, proximal to distal. Went ahead and fixed the first. I did not see any substantial, I went ahead and pinned the first, same incision that we talked about before. Here's a video kind of showing my sequence. So medial, and then I go ahead and pin the Lisfranc complex. check my lateral. I like getting a simulated weight-bearing x-ray. It makes me make sure that I don't see anything off. It makes sure that I know what I'm looking at the time of the fixation, and make sure everything gets reduced. And then this is where I could maybe argue maybe it doesn't make as much sense, because I bridge plated the first and then did flexible fixation across the Lisfranc joint. But it was so stable once I fixed the first that I felt like this would give her the stability to that area that I could use and still have some ability for some motion. And it allows me to let her get on it pretty quickly once we get going with things. And I'm not as worried about hardware failure or hardware breakage. And I feel like if her first TMT plate, if she plays with that on there for the first season, I have no problem letting her kind of go with it. I'm not worried about anything breaking across the joint in this particular case. And in worst case, she breaks the plate and the screws are all extra articular, and we just take those out and we leave the screws, the screw tips or something like that. But this is our follow-up x-ray. Here's at 3 months. You can see that our alignment's well maintained. And what I really liked was looking at the oblique view and seeing how that second TMT joint now has been pulled in and it's nice and stable. And the first is stable as well. And so it'll be interesting to see how she does over her first season. This is my rehab protocol. Again, this is out of Porter's article. This is a pretty well done rehab protocol that I think is quite helpful. And then I mentioned, I talked about this earlier, I think when it comes to ORIF, we do consider removing the hardware in a lot of these cases. I would not disagree with that at all. I tend to remove hardware in my athletes, at least talk to them about it. I've waited a little bit longer. It used to be 3 to 4 months. Now it's probably 4 to 6 months if I can wait just a little bit, because I do think they widen just a little bit after you take the hardware out. So I try to get them to 4 to 6 months, and I'm a little more aggressive with letting them play with the hardware in. And I think that's a very safe thing to do. But at the end of the day, there's really no great evidence to suggest that hardware should come out or shouldn't come out. That you're going to get different opinions on them depending on who you talk to. I think it's one of the things that you have shared decision making with the patient and the family, and a lot of times they elect to get them out, and they feel better with getting the hardware out in some of these cases where you've bridge plated the joint. And one other thing to kind of mention is, what about suture button fixation or flexible fixation for these Lisfranc injuries? We know that in the syndesmosis, we've seen some some studies showing improved outcomes with flexible fixation. And so do we need to consider that in the Lisfranc? We do have options for suture button or brace kind of constructs. There have been some studies that have looked at return to activity, showing a pretty high return to activity. AOFAS scores are high, VAS scores are high. Hardware removal rate is 0% because now you don't have anything in there. And sometimes there are cases where I will actually use this construct and I'll bridge plate, knowing I'm coming to take out the bridge plates, but then I know I still have some hardware that's in there holding the ligaments stable. 100%, this was one looking at radiographic results. 100% of patients maintain postoperative alignment, no diastasis or instability reported. There's biomechanically, it's a little bit of mixed results. Screws may limit diastasis slightly, but I personally feel like when I take the hardware out down the road, they gap open just a little bit. And so I've seen some that when I use flexible fixation, clinically, they do really well. Sometimes I'll see just a little widening occur over time. So here's a case example of a 14-year-old male. And, initially he was seen by one of my peds colleagues and said, well, young kid, open physes, they don't need anything. And I don't necessarily disagree. It's pretty rare that I see a kid with open physes that has an unstable ligamentous injury. Here's his x-rays. Here's his CT scan. And you can see, I think I showed this CT scan earlier, but you can see some widening there at the Lisfranc complex. And if you look at his three-dimensional imaging, you can flip it around, and those dorsal fractures, I wasn't really that concerned about. If it had just been that, it was more that flex sign off the base of the second metatarsal. And when I got a weight-bearing x-ray, sure enough, he gapped open. So again, if he had come in with those fractures that you see dorsally and he didn't widen, I just leave this thing alone. But because he widened, it was indicating that there was a primary ligamentous injury. So we went ahead, and this is a case where I used such suture button fixation. I open it, clean it out. I sometimes will pass that wire halfway through. I don't know, do I need to get more dorsal? Do I need to be more low plantar? Do I need to be right in the middle of the area? I think you get different opinions on it, and I kind of think we're still figuring out the optimal treatment. But then, place my wire, make sure I like the alignment. Here's our postoperative x-rays. So this one here had a internal brace construct where I fixed it with an interference anchor, and then the tapes get brought over to the middle cuneiform for additional intercuneiform stability. And I do that pretty much all the time on these because I feel like it has some additional fixation with little downside. So for athletes, Lisfranc injuries, key takeaways: make sure you recognize them. Make sure you're looking for things like plantar bruising. Scrutinize the x-rays, bring them back a week later. Don't just like send them out and say you'll be fine. Like, bring them back if you have any concerns. Get weight-bearing x-rays, get advanced imaging. Be thinking about this injury, because otherwise you can miss it. And I think you need to be athlete specific. I think ORIF is going to be the preferred construct probably for most physicians for athletes. Primary arthrodesis reserved for, in my hands, the bad ligamentous injury in the non-athlete, or cases where there is articular injury, revision, arthritic changes, those kinds of things, and probably in a more limited fashion than doing like first or third. Hybrid constructs, I think, are promising, and I think we need to see more long-term data on that, figuring out when to use it. You don't have as much of that rotational stability from it, but there's some advantage to having a little bit of flexibility. And clinically and anecdotally, patients have been very happy with that, and especially if you don't have to come back and take out hardware. So I think prioritizing joint preservation, get stable fixation, individualize your surgical and rehab planning for your high-demand athletes, and I think you can see a good results with this. Thanks very much. Really appreciate the opportunity. Sorry, I probably ran a little long there.
Thank you, Nick. Nick, you can stop sharing. Yeah. So thank you, Nick, for yet another comprehensive talk. It was long, but it was worth it. I mean, in addition to the key concepts, you've taken through a lot of clinical examples. I mean, that's the key.
Mm-hmm.
And Nick, few questions. Nick, the biggest challenge is with the ligamentous Lisfranc, right? The pure ligamentous Lisfranc, which you see maybe more in athletes. And that has been the debate with the paper you mentioned, Chris Coetzee. I mean, it started in 2006, if I remember, JBG's American, long ago.
Yep.
And in those papers by Coetzee, the ligamentous Lisfranc primary fusion was better, right?
Mm-hmm.
And what is because you treat patients in the same category, athletes and more of ligamentous, isn't? Am I right?
Yeah, in the athletes, the more the ligamentous. Yeah.
And do you feel a fusion would be advantageous?
The way that I read Dr. Coetzee's paper is, those are that case that I showed with the homolateral dislocation. Like, if I see that guy, that kid, or that patient comes in from a car accident or a fall, and they're in their late 20s, 30s, that kind of thing, I'm doing a fusion for that case. I'm not even questioning it at all. We did a case like that on coin flips with orthobullets, and you can find it. We could even reference it, but where we talked about that kind of case, and it was interesting because, to me, that's the case that Dr. Coetzee is talking about, like that bad dislocation. Because I've tried it. I've tried fixing those where I'm like, oh, I can make this perfect. I'll fix it. I take the hardware out down the road, and sure enough, it starts to shift over. They get arthritic changes. You can already see that young kid, he's already getting arthritic changes, and we haven't even done anything with the hardware. It's only like 6 months. So I think in those cases, to me, that's the spirit of the paper. Those cases that have the homolateral dislocation with that's all ligamentous, but in the patient that's even 30 or 40, If that was me, I'd say just do a fusion, like right out the gate. I think that's going to be a better option for those patients because once they're fixed, they're done, they're back at work by 6 months, which I think that's great. I mean, that's a big deal for that. Otherwise, you're coming back, you're doing more surgery. That I think that's the patient I'm thinking about the fusion. For the ones that are these more subtle ligamentous injuries, I think we can fix those fine. And even in the non-athlete, like sometimes I'll fix those as well.
Great. Uh, Now, this is just a recap of what you've already done. I just want to get the message very clear to the audience, Nick. Okay. And the other one is flexible fixation, the tightrope. And what is the ideal patient for a flexible fixation? I mean, that's a trend, right? You can see a lot of guys
Yeah.
saying, I like to put a tightrope in the Lisfranc.
Yep.
So what would be the
That,
ideal scenario?
I think we're figuring that out. So for me, if I get in there and I'll stress them all initially, and if the first TMT joint is pretty stable, then I think those are ones where I will do flexible fixation. And if the first is involved where there's instability like that, where that some of those cases I showed, and I need to bridge plate that, and then I'll go ahead and I'll bridge plate it, and then I'm like, well, I'm using rigid fixation. Does it make sense to use hybrid? Like I'm still trying to figure that out. I will say that anecdotally and seeing patients back, they seem better with the flexible fixation. Like they just seem to do a little bit better. And that's totally anecdotal. And there's something about having a little bit of retained motion there. I've seen them gap just a little bit, but honestly, if I go in and take out hardware and I come back at 6 months and I take out, like, let's say I take out those screws and I get a good weight bearing x-ray, they widen just a little bit, even at 6 months. And they're not bothered by it, but they'll still gap open just a touch. So I'm still figuring out where the flexible fixation lies. And the other thing too is you don't get, like, the flexible fixation doesn't get this, it gets one plane. So I think we probably need to rethink, like, how do we need to have like two, biplanar or something, like where you're getting recreating the plantar bands and the dorsal band and then, intercuneiform space. But those are the questions I have. I think it's a lot of promise, but, and I think we'll use it more and more. Some people talk about, fixing it with screws and then coming back, like in a high-end athlete, putting in, when you take the hardware out, putting in flexible fixation at 3 to 4 months, which that actually makes a lot of sense. It's a little more expensive, but if you take a professional athlete, that might be worth it.
Thank you. And Nick, now some of the cases where we have the entire midfoot gone off, right? You have to address the lateral column as well. And the lateral column is slightly mobile. And is K-wires the standard on the lateral side? Because we need that movement, right? Or just you would still go with screws?
You're talking about fourth and fifth TMT?
Yeah, exactly.
I have gone away from putting K-wires in the fourth and fifth. And if you talk to Dr. Mason, Lyndon Mason, he's done some work looking at whether or not that's necessary or not. And I think the conclusion has been largely that it's not. So I'll spend a little more time on the first to third, make sure those are right, or in the NC joints. And a lot of times, if you make sure you restore the anatomy there, the fourth and fifth kind of fall into place. And provided that they're not still, like, it's one thing if they're still subluxed and they're off, then I think you probably go ahead and pin them. That would be very reasonable. But a lot of times, if you get the anatomy right, they fall into place and they're relatively stable. I would just leave those. I don't think you necessarily need to K-wire those in those cases. So I tend to not put any fixation across the fourth and fifth.
Thank you, Nick. Nick, I think that's all the questions for this program. It was fantastic listening to you once again and really look for more in the future.
Yeah, sounds great. Can't wait to do it again. Thank you so much for the opportunity.